मेरे को कैसा मालूम पड़ रहा है यार? Okay, thank you. Good afternoon, all of you. Today I'm sorry for this unscheduled class at 2 o'clock. In fact, in the morning I had started at around 10:05, 10:10. After speaking for around 40 minutes, then it was realized that the class is not streaming. Hence, we have rescheduled this for today. Now, to begin with, before I start the topic, I just wanted to inform you all that in the third week of April, that is this month, somewhere after 15th, in between the week of 15th and 7th and 21st, you will have your first formative assessment. Now, this formative assessment will be an online assessment. It will be of 1.5 hours, that is 90 minutes, and it will be a 50 marks paper. The question paper will be released about 5 minutes before the start time. Let's say around, we will conduct it from 10 o'clock to around 11:30. At 10 o'clock, the question paper will be released. You need to answer the questions in a white paper, and then after you have finished it, you have to scan that from your device and send it to the email. There are all the three departments will have different mails for these exams, and to that particular email ID you need to send your answers from your email ID, and the email IDs will be known to you little later. Sometime it will be uploaded on the website. The syllabus has also been uploaded, and now coming on to specifically to our physiology. In physiology, whatever we have covered in these 2 months, that is the general physiology and the nerve muscle physiology, that will be the syllabus for your first formative assessment. The paper will be of 15 marks, and this 15 marks is divided. This 50 marks is divided into 3 questions. The first will be an essay question, which will be a structured question. Structured question in a sense that there will be main topic based on that particular theme. There will be 6 other questions, or 4, 5, or 6 questions related to it, each carrying 2 to 3 marks. So in that way, the 15 marks question will be divided into 5, 6 subsets, which will be related to the main theme question, and you have to answer those. The next section will comprise of around 5 marks questions, which will be 4 in number, so that will be around 20 marks. And the next will be very short answers, which will be 5 in number, carrying 3 marks each. So this will be total 50 marks paper, and most of them will have 2 components of it. One of which will be the physiology related and direct from physiology, plus there will be additional factor in the question where you need to understand the physiological pathological implications of that. What I mean here is that it will be mostly a clinical related question paper subject to physiological basic principles, and it is mostly analytical. Very few direct questions will be there, but based on the concepts you have to think and write the answer. So basically the meaning here is, if you understand the concept, if you grasp the concept, then you can able to understand and write the paper. Otherwise, simply by hearting it may not help you out. The same thing applies to biochemistry and anatomy. Any of the department faculty will brief you on this. The final dates will let you know. The paper will be on 3 days, on 3 alternate days. The intervening day or the intervening gap between the 2 papers, the theory classes will be cancelled. Now let us now go back into our topic, where today we will deal with the clinical aspects of the clinico-physiological aspects concerned with general physiology and nerve muscle physiology. Now, the last thing is, in the neuromuscular junction, you would have been briefed about what is the structure, anatomical structure of the neuromuscular junction, what is the integrity of the neuromuscular junction, and the functions of the neuromuscular junction. Now, basically, the neuromuscular junction, as the name suggests, is a junction between a nerve and a muscle. we know that all the muscles in the body, let it be a skeletal muscle or a smooth muscle, is innervated by neurons, or it has a nerve supply. That junction where the nerve ends and innervates the muscle is called as the neuromuscular junction. Say for example, let us take the example of a skeletal muscle. Now the skeletal muscles of the upper limb, the skeletal muscles of the lower limb, or the abdominal muscles or the facial muscles, all these are innervated by certain nerves, and these nerves are called the efferent nerves or the motor nerves. Based on the signals sent by these motor nerves, the muscles will contract and relax. So a proper functioning nerve and a proper functioning muscle with a proper functioning nerve muscle junction, neuromuscular junction, is necessary for the muscle to perform normally. Now say for example, let us see the skeletal muscles of the upper limb or the skeletal muscles of my fingers. Now if I want to write, or if I want to move my hand, or as I am speaking, the facial muscles are contracting and relaxing. So for this, the signals for these muscles to contract comes from a nerve which is called as a motor nerve or the efferent nerve. Now where the motor nerves end, and at that beginning of the muscle there is a junction which is called as a neuromuscular junction. Now this neuromuscular junction is consisting of a nerve end, and this is the terminal end, and here you will have the muscle membrane. So here there is a nerve, a muscle, and this junction is called as a neuromuscular junction. For the proper functioning of this neuromuscular junction, you will find that whenever an impulse comes here, the acetylcholine is released. Acetylcholine is released into the gap here, synaptic cleft, where it generates a potential which is known as a miniature end plate potential, and this potential, now this acetylcholine will bind on a receptor which is present on the membrane, muscle membrane, which is also called as a postsynaptic membrane. And once the acetylcholine binds to these receptor, the sodium ions in the muscle part will open. Once the sodium ions open, the depolarization or action potential is generated. Once that action potential is generated, it causes the release of the calcium ions. When the calcium ions are released, it causes the binding up of the actin troponin cross bridges, and once there is a binding take place, a power stroke is executed. When the power stroke is executed, the muscle contracts, and once the contraction is over, the calcium moves away from the actin myosin troponin complex. Once this calcium moves out, the relaxation begins. There is an unbinding of the cross bridges takes place, and the sarcomere length returns to back to normal. And once all these sarcomeres, all the muscle fibers are relaxing and reach back to normal, relaxation is complete. In this way, a single cycle of contraction and relaxation takes place. So for this, it is very essential that, and this process of this transmission of nerve impulse across the skeletal muscle, across the neuromuscular junction, is happening in all the muscles of the body. Now, what are the basic prerequisites here? So, if you see this nerve, this is the nerve here, these are the endoplasmic reticulum and the cell organelles. These are now sending these synaptic vesicles, and these vesicles come to the end of the neuron. Here you will find that acetylcholine is already present. Once these are ready, you will find that into the synaptic vesicles acetylcholine moves in, and now there are secretory granules which are ready with acetylcholine. Now these granules move towards the nerve end, and once the impulse travels, it reaches the end, and once it reaches the end, you will find that the acetylcholine is released into the synaptic cleft, and once it is released, you will find that as the quantity of acetylcholine goes on increasing, the number of acetylcholine molecules binding on the receptor, imagining the receptor here, will increase, as a result of which you will find that a miniature end plate potential is generated. Once this miniature end plate potential is generated, you will find that the transmission has been successfully occurred. Now here, if you see back at this membrane, here it is acetylcholine. Acetylcholine is binding on to this receptor. This is the ACH receptor or the acetylcholine receptor on the postsynaptic membrane or the muscle membrane. After this binding is occurred, the action potential spreads down throughout the length of the membrane, throughout the length of the muscle, and then activation of the actin myosin filaments takes place and the muscle contracts. Meanwhile, as this process is happening in the muscle mass, there is an enzyme which is called as acetylcholine esterase. This acetylcholine esterase will get liberated, will act on this acetylcholine, break down the acetylcholine into acetate and choline. The acetate goes back into the circulation. The choline part goes back into the nerve end to be again in the presence of an enzyme acetyl-CoA get resynthesized into acetylcholine. So now once this acetylcholine esterase enzyme breaks down the acetylcholine, the action of acetylcholine comes to an end and the neuromuscular transmission stops. Now, if you understand this background or the basic concept here, we go on to the pathology here, where we will see this particular condition which happens because of diseases at the neuromuscular junction, and the commonest disease at the neuromuscular junction is called as myasthenia gravis. Now, one of the features of the myasthenia gravis, if you see here, is the drooping eyelids. If you see the patient, the person is not able to completely open his eyes. In other words, he is not able to keep his eyes open because the eyelids are drooping down. So this is called drooping of the eyelids. So in myasthenia gravis, the earliest symptom is that you will find that there is a drooping of eyelids. Now, what is myasthenia gravis? Myasthenia gravis is a disease of the neuromuscular junction. This disease is seen mostly in the ratio of around 1% in a count of 20,000. That means 1 is to 20,000. You sample study around 20,000 people, you may get one person who is suffering from myasthenia gravis. And if you take such 100 patients of myasthenia gravis, you will find that the female is to male ratio is around 3. So in other words, it is more common in females than in males by ratio of 3 is to 2. Now, what happens or what is the pathophysiology basically in myasthenia gravis? In this, you will find that the body starts producing antibodies. Now, the antibodies are produced against the receptors. Here. So, now the body for some reason starts producing antibodies against the acetylcholine receptors. Now, once the antibody titer or the count goes on increasing, it stops the transmission of impulse from the nerve to the muscle. How does this happen? The antibodies which have been generated in the body will compete along with the acetylcholine, and instead of acetylcholine coming and binding here, you will find that the antibodies comes and binds to the receptor, that is the acetylcholine receptor. So first point, the antibodies are developed against the acetylcholine receptors. Once the antibodies are bound or produced against the receptors, three things can happen. One, it comes and binds onto the receptor so that there are no receptor areas present for the acetylcholine to bind. Hence, there is no action of acetylcholine. Hence, the transmission does not take place. Secondly, the antibodies can start destroying the receptor itself. Third, the other pathophysiological reason is the antibodies, apart from destroying the receptor, also will destroy the postsynaptic membrane. That is, this part of the muscle membrane gets destroyed. Once it is destroyed, though acetylcholine is being released from the nerve ending, there is no receptor for it to act. Or even if the receptor is there, there is no vacant site for acetylcholine to bind because the antibodies is already binded or bounded to the acetylcholine receptors. In this way, the neuromuscular transmission across the junction gets blocked. So what do you see? So the first thing is that this neuromuscular junction transmission is important for skeletal muscles. One of the earliest organ to get affected is the eye. You know that the keeping the eyes open is also an active part where the oculi muscles or the muscles around the eye have to keep contracted to keep opening. So opening and closing of the eyelids or this blinking is an active process. Once there is this in patients with myasthenia gravis, you will find that this acetylcholine is not generated, is not acting, hence the person will find it difficult to keep his eyes open. So the eyelid will start dropping downwards. So the first symptom is the dropping or the drooping of the eyelids, dropping of the eyelids, first in one eye, then later on in both the eyes. So his eyes will be partially open. Now apart from this system, apart from this, the other things to be getting affected is the facial muscles. The facial muscles are also requiring lot of neuromuscular transmission so that they contract. The expressions on the face are a part of the skeletal muscle contractions which are happening in the various group of muscles, facial muscles, involving the muscles of the forehead, muscles of the eye, and the muscles of the cheek. So if there is a disease of the transmission of impulses, there will be an expressionless face because the facial muscles are not contracting. So a expressionless face, a drooping of one eyelid or drooping up of both the eyelids are the early symptoms which the patient are the early things which you will see in a patient with myasthenia gravis. The other conditions which you will see here is easy fatigability, or the patient will complain of getting tired very easily or not able to sustain a muscular activity for a prolonged period of time. The reason being, initially, the acetylcholine will be synthesized. It may act, it may cause certain muscle contraction, but when more and more amounts of acetylcholine are needed, there will not be enough receptors for the acetylcholine to bind. So, complete contractions or a contraction of the muscle or muscle activity for a long period of time cannot be sustained. Hence, you will find that the patient, after doing little bit of work, will get easily tired. So the other complaint will be the person in the morning hours when he gets up from sleep will be very fresh, he will be active. But once he starts doing his routine activity or he gets back to work in his routine way, after few minutes or few hours, he will feel that he is tired and he needs to take rest. So easy fatigability, feeling fresh in the morning, getting tired in the initial morning stages itself, and this tiredness getting released by a bout of sleep and again becoming active are the few symptoms which you see in myasthenia gravis. Now let us see how can we treat this. If you understand the pathophysiology, the treatment part also becomes easy. First, as I said in the earlier slide, the first thing is that the neuromuscular junction, you will have to have acetylcholine binding on the receptor. Now, if you give some drug which prevents the destruction of acetylcholine, say for example, some acetylcholine is here, it is bounding to the acetylcholine receptor. Now, if you give a cholinesterase, a drug which prevents the action of acetylcholinesterase, this enzyme will prevention or blocking this enzyme will prevent the destruction of acetylcholine. So whatever acetylcholine is acting will show its effects for a little longer time so that the muscular activity can be sustained. So the first thing is giving anti-acetylcholine esterase drugs. I'll come back to this again. Acetylcholinesterase is an enzyme which destroys the acetylcholine and stops further action of acetylcholine. So once this enzyme acts, it breaks down into acetyl acetate and choline, the choline part gets separated and the acetate part gets separated, thus bringing an end to the action of acetylcholine onto the receptor. Now, once if you give an enzyme that prevents the action of acetylcholine esterase itself, what will happen? Acetylcholine esterase will be ineffective in destroying acetylcholine. So, the acetylcholine, whatever amount is being released at the neuromuscular junction, will show its effects for a long period of time. So, neostigmine is one drug which will cause or treat this neuromuscular, will treat myasthenia gravis, and that acts by increasing the amount of acetylcholine in the neuromuscular junction. The other is the corticosteroids. Now, the pathology lies in the person developing antibodies against the acetylcholine receptors. Now, when you give corticosteroids or certain immunosuppressive drugs, it will suppress the immune system of the body and prevent the lymphocytes from producing antibodies against the against the acetylcholine receptor. The third thing is plasmapheresis. Plasmapheresis is a process where the plasma is run or washed out. When it is being run through a machine or is being washed out, all the antibodies against the receptors are removed and the plasma is reintroduced into the body. So after doing 3-4 cycles of these, a couple of cycles of plasmapheresis, you will find that the plasma now is free from the antibodies, so the person can remain normal for some time. Again, but if the body starts producing the antibodies again the titer will increase, the antibody titer will increase, and the symptoms may recur. So the problem here is that recurrent plasmapheresis has to be done. So this is about myasthenia gravis. Then there is another condition which is known as Eaton-Lambert syndrome. Now, what is this Eaton-Lambert syndrome? This Eaton-Lambert syndrome is a disease which affects the neuromuscular transmission, but the pathophysiology here is different. Now, in this Eaton-Lambert syndrome, what happens is there is a genetic defect and it prevents the entry of calcium ions into the neuron. Now we know that once before this acetylcholine has to be released, it has to bind with the calcium ions. Once the calcium ion binds to the synaptic vesicles, they move to the nerve terminal and get released. If in this disease of Eaton-Lambert syndrome, you will find that the calcium channels are blocked and there is no entry of calcium into this nerve terminal. When there is no entry of calcium into this terminal, this entry of acetylcholine into this synaptic vesicle and the subsequent release does not happen. When that does not happen, there is no acetylcholine itself present there for the neuromuscular transmission to take place. So I hope you understood about the myasthenia gravis, the pathophysiology, the symptoms, and the physiological basis for the treatment of this disease. Now let us go briefly on to some other things. Some other clinical oriented things. One is the drugs which are acting on the neuromuscular junction. When you see the neuromuscular junction, there are certain drugs which are mimicking the action of acetylcholine. When they act mimics the action of acetylcholine, they can either stimulate the release of acetylcholine or they can block the drug release of acetylcholine. So those drugs which are stimulating the release of acetylcholine are called as parasympathomimetic drugs. So parasympathomimetic drugs are those drugs which will mimic the action of acetylcholine. Now these drugs can act by stimulating the nicotinic receptors, and one of the example there is nicotine. Then there are certain drugs which can act on the receptors by preventing the action of acetylcholine esterase. So when these drugs are known as cholinesterase inhibitors. So cholinesterase inhibitors are those drugs which will prevent the action of the acetylcholinesterase. So when these inhibitors will prevent the action of acetylcholinesterase, they will not destroy acetylcholine and the action of acetylcholine is prolonged. So such drugs are examples are neostigmine, pyridostigmine and aminonium. So these are some of the drugs which come under the classification of cholinesterase inhibitors, and this is the neostigmine which is used to treat myasthenia gravis. So these are the two drugs which will mimic or which will act in a similar way to acetylcholine, either by stimulating the receptors directly or by prolonging the action of acetylcholine by inhibiting the enzyme which destroys acetylcholine. Next, there are certain anti-muscarinic drugs. Anti-muscarinic drugs are those drugs which block the action of acetylcholine and they are known as anti-muscarinic drugs. This we can deal again when we deal with autonomic nervous system. So now these are some of the drugs like neostigmine, physostigmine and diisopropyl fluorophosphate, and these drugs will stimulate the neuromuscular junction by inactivating acetylcholine. Now there are certain drugs which are known as curariform drugs. These curariform drugs are drugs which will block the action of the acetylcholine receptors. So either they can block the neuromuscular junction by inhibiting the acetylcholine release, which is known as presynaptic block, or preventing the action which is known as a postsynaptic block. Now, before we close, let us discuss some things about the other aspects of the clinical aspects. In the last class, one of the example clinical related thing which I had explained to you was regarding local anesthesia. Then I had also explained the relationship of tetany. Now, what is tetany? Tetany is a condition where you will see that the muscles are suddenly going into spasm, and these spasms are called as tetanic spasm. It is also known as carpopedal syndrome. Carpopedal spasms. Now, why does this carpopedal spasm happens? It happens because of deficiency of calcium. Normally, the serum calcium levels in the body is somewhere around 9 to 11 milligrams. Now, whenever there is a decrease in the calcium levels, it is called as hypocalcemia. When there is a hypocalcemia, you will find that suddenly a muscle, a whole group of muscle or some of the muscles will start contracting in an irregular fashion, resulting in the person experiencing certain twitches. The twitching can be somewhere in the forearm muscles, generally seen on the eyelids, where you will find that suddenly there is a twitching of the muscles of the upper eyelid, or you will find that there is a twitching of the facial muscles. Now these twitchings are because of the decrease in the calcium levels. So whenever there is a fall in the calcium level below 9 milligrams, it is called as hypocalcemia, and you will observe tetany, T-E-T-A-N-Y, and the tetany, if the calcium level is fallen down to so drastic level, you will find that the fingers are all going into a spasm like thing, and that is known as a carpopedal spasm. Here the physiological importance is, how is that there is a fall in the calcium level but is causing muscle spasm, whereas we generally say that calcium is necessary for muscle contraction. The thing here is, the calcium and the sodium ions are closely related. When we see the calcium ions are released into the endoplasmic reticulum, is released into the ICF and into the sarcoplasm, and when they are released into the sarcoplasm, they cause the opening up of the active sites, and once the opening up of the active site occurs, binding of actin myosin filaments takes place and the contractions takes place. But here, whenever there is a decrease in the calcium levels, the thing which happens here is, the sodium channels which are present in the muscle membrane become more excitable, because a decreased ECF calcium, that is decreased calcium in the extracellular fluid, will lower the threshold of the sodium channels to get excited. So what excitability or the critical firing level is somewhere around minus 70 millivolts will get reduced to around minus 80 millivolts. So they will become highly excitable, and because the excitability is increased, as a result of decreased calcium ions, you will find that the muscle shows abnormal contractions or spasms. Then the other clinical importance here is of sodium potassium pump. As I said earlier, the sodium potassium pump is responsible for maintaining the cell volume and the ionic concentration. The sodium potassium pump is also a pump which moves the sodium out and maintains the electrical neutrality inside the cell, whether it is a smooth muscle or whether it is a cell or whether it is a cardiac muscle. So there is a sodium potassium pump blocker which are called as cardiac glycosides, and these glycosides are used in treating heart failure. So digitalis is one drug which is a cardiac glycoside, and this digitalis is a drug which improves the pumping action of the heart. We know that the cardiac muscle is a muscle, it's a pump, and all the fibers contract. When all the fibers contract, blood is pumped out of the heart. So that is the pumping action of the heart is because of the calcium which is present in the muscle fibers. Now in a patient who is having heart failure, it means that the pumping ability of the cardiac muscle fibers is reduced. Now how do you treat this? This is treated by cardiac glycosides. How do you treat which is the cardiac glycoside? Digitalis. How does digitalis helps in improving the contractility of the cardiac muscle fibers? Here the digitalis, when you give the patient digitalis, it blocks the sodium potassium pump. When you block the sodium potassium pump, what is happening? The movement of sodium ions from inside to outside is not happening, and the movement of potassium ions from outside to inside is not happening. So when this is not happening, that is when the sodium potassium pump is blocked. When the pump is blocked, there is more amount of sodium ions. The sodium ions will compete or stimulate the calcium ion to remain in the sarcoplasm and not move from the sarcoplasm into the sarcoplasmic reticulum. So because of this, the calcium concentration remains outside to a more longer period of time. When more calcium is available in the sarcoplasm, then the more the powerful will be the contraction, and when the contraction improves, the pumping ability of the heart improves. When the pumping ability of the heart improves, that means the cardiac contractility is improving and the cardiac failure is getting treated. Then there are other things about the clinical physiology where we deal with body fluids. When we see about the body fluids, now let us briefly discuss some of the clinical factors which are released with the osmosis. We know that osmosis is a process where water flows from a semi-permeable membrane from one compartment to another compartment where the concentration of the solute is lower to the one where the solute concentration is higher. Now this osmosis can occur till the concentration gradient on both sides of the membrane becomes normal. The pressure which is required within the compartment, whether to stop further osmosis, is known as osmotic pressure. Now these two terms are very important in terms of body, maintaining the concentration of the solutes and the solvent in the body. We know that the Body fluids are divided into two compartments, the ECF compartment and the ICF compartment. ECF is the extracellular fluid and is outside, and ICF is the concentration, is the fluid which is present inside the cell and is known as the intracellular fluid. We have got water on both the compartments. We have got sodium concentration in both the compartment. We have got potassium concentrations, called calcium concentration in both the compartments at a different levels. Now, if you see the whole concentration of the ions in the water and finally see the osmotic pressure, you will find that the osmotic pressure in the ECF and the osmotic pressure in the ICF is normal, is same. Similarly, the concentration is measured in milliosmoles per liter. If you overall see the ECF milliosmol per liter concentration and the ICF milliosmol concentration per liter, you will find that it is always constant. It is same. Where the milliosmolar concentration remains constant or in equilibrium, such a solution is called, such a state is called as isotonic solution or a isoosmotic solution. Now, in a isotonic condition, you will find that the concentration, overall concentration of the electrolytes on both sides, that is the ECF and the ICF, is normal. Now, if the concentration of the sodium ions is increased or the potassium ions is increased in one particular compartment, then such a compartment has more number of solutes, and that is known as hypertonicity or a hypertonic solution. If the concentration of the solutes falls below normal or falls less than the normal, then such a solution is known as a hypotonic solution. Is known as a hypotonic solution. So remember the three words: isotonicity, hypertonicity, hypotonicity. Similarly, there will be either isoosmolarity, or it can be hyperosmolarity, or it can be hypoosmolarity. Now, when do we see hypertonicity or hyperosmolarity, and when do we see hypoosmolarity or hypotonicity? Let us see hypertonic solution. Now, in an isotonic solution or in isotonic conditions within the body, normally the isotonic condition is such that when 300, the concentration of the solutes is somewhere around 300 milliosmoles per liter. At this particular concentration, when the ECF concentration is 300 milliosmoles and the ICF concentration is 300 milliosmoles, the body is said to be in an isotonic condition. Now, suppose for some reason the concentration of one of the electrolyte, sodium, is increased in the ECF. So that is called as hypertonicity in the body. The concentration of the sodium ions in the ECF can be increased in two conditions. One, either there should be an increased sodium concentration in the ECF, or there should be a loss of water from the ECF without a corresponding loss of sodium ions. So that will result in a hypertonicity in the body or hyperosmolarity. I'll repeat this again. The concentration of the solutions in the ECF comes to around 300 milliosmoles per liter, both in ECF and ICF. That time it is isotonicity. Now suppose the concentration, for example, let's say sodium concentration increases in the ECF compartment. That means the concentration of the electrolytes is increasing. It results in hypertonicity or hyperosmolarity. Now, when can this happen? This should happen either there should be an increased sodium ion concentration only in the ECF, or there should be loss of water from the ECF without a corresponding loss of sodium ions. So it will result in hypertonicity. Then what is hypoosmolarity or hypotonicity? Hypotonicity is a condition where you will find that the concentration of the electrolytes fall below normal. When they are falling below normal, then it is called as hypotonicity. Now, when this hypotonicity should occur? This hypotonicity should occur when there is a loss of sodium ions from the body without a corresponding loss of water, or there should be an increased volume of water in the body without an increase in the sodium ions. So in both these conditions, you will find that there is a hypotonicity happening. Now let us see what happens in hypotonicity to the ECF concentration and the sodium concentration. Suppose there is a condition where you will find that there is a hypotonicity. There is a hypotonicity which is happening because of the loss of sodium. Say for example, sodium has lost from the body without a loss of water from the body. That is in dehydration, where you find that the sodium intake, the sodium loss has not occurred, but there is a loss of water from the body. In such a situation, you will find that the water is lost, but sodium remains. It causes increase in the sodium ion concentration. So, in such a condition, what will happen is the sodium ion concentration will remain there. There is a dehydration condition where water is lost but the sodium is still present. In such a condition, you will find that the sodium concentration in the ECF will increase when there is a hypertonicity. You will find that the water concentration ECF volume is decreased, and also you will find that the ICF volume of the water is increased. So here you will find that there is a vomiting which is happening. There is a loss of water which is happening, but this loss of water, say for example you are sweating or you have got done a severe exercise. So when you do a lot of exercise, there is loss of water from the body, or when you are getting dehydrated, water is evaporated through sweating, but sodium is still intact in the body. In such a condition, you will find that hypertonicity, and it is because of dehydration where you will find water is lost. So when water is lost, what is happening? The sodium concentration is increasing, the ECF water volume, ECF volume is decreasing, the ICF volume is decreasing. Now, if you find that there is a hypertonicity because of overhydration, there is a hypertonicity where there is an overhydration. So now what will happen? Overhydration, you have given sodium. Overhydration I means you have taken more of salty food. Say for example, if you have taken some food or something where you will find that you are overtly hydrated with increased sodium ion concentration. So here you will find that there is an increase in the sodium concentration correspondingly, but the sodium concentration will increase, the water concentration will also increase in the ECF, but it will decrease in the ICF, because I will tell you why. Sodium has gone inside. Because there is an intake of sodium into the body, the concentration of the sodium ions is increasing, the osmolarity in the ECF is increasing. When the osmolarity in the ECF is increasing, there is a movement of water from the ICF into the ECF, so that the osmolarity comes back to normal, as a result of which the ECF volume increases, the ICF volume decreases of water. So this is the condition. Both the conditions, sodium concentration is increasing, but in one place you will find that the ECF volume is increasing, in the other condition you will find that the ICF volume is decreasing. Similarly, when we come on to hypotonicity, hypotonicity means what? There is a decrease in the sodium concentration. Now, when there is a decreased concentration of sodium, say for example, you have taken you have consumed lot of plain water. Say 1 or 2 liters of water you have consumed without any electrolytes. Especially this happens when you are overhydrating yourself. So there is an increase in the water content in the body. When there is an increase in the water content in the body, what is happening? Salt has not increased, sodium has not increased. So because the same amount of sodium is now present in large or in a large quantity of water, the sodium concentration will come down, but you will find that the ECF volume and the ICF volume will increase. So in hypotonicity, there will be a decrease in the osmolality, but correspondingly you will find that there is an increase in the ECF volume and increase in the ICF volume. Now let us see, for example, what happens if there is a hypotonicity because of vomiting or diarrhea. So in vomiting and diarrhea, what is happening? The fluid is getting lost. The sodium in vomiting, especially the fluid, is also getting lost. There is a dehydration which is happening. Because of the dehydration, you will find that sodium is also lost, water is also lost. The sodium concentration falls, the ECF volume, water concentration also falls, but the ICF volume gets increased. So these are the four conditions where in hypo and hypertonicity, either during overhydration or during the dehydration, you will find changes in the concentration volumes here. The other condition which we would see is last class which I had talked about was demyelinating disease. We know that there is a demyelination happening in the body. There is a myelin sheath which is covering the neurons, especially if you see the Erlanger's and Gazinger's classification. A alpha fibers are the fibers which are myelinated fibers. They are having thick neurons, and that thickness is because of the myelination of neurons. The myelination of the neurons is because of the myelin sheath, and this is absent at the Renshaws and is absent at the nodes of Ranvier. Now in certain diseases you will find that the myelination does not happen, or if the myelin sheath gets destroyed, it does not get remyelinated. This is leading to a myelination disorder or a degeneration disorder where the neurological conduction is nerve conduction velocity is reduced, the conduction is not happening normally, and especially it is seen in diabetics. So in diabetes you will see that the neurological complaints, once the neurological complaint starts in diabetes, then we say that they are going into diabetic neuropathy. And why they go into diabetic neuropathy? Why the diabetic people go into neuropathy? Because of the high glucose content, the myelin sheath does not gets destroyed. So the velocity of conduction takes place. When the velocity of conduction slows down, the natural reflexes and the responses to the various situations in the body, for example, the baroreceptor reflex, the chemoreflexes, or the autonomic reflexes get slowed down, resulting in complaints which is called as diabetic neuropathy. With this, we will finish off for the class. We will end the day. And again, we will meet on 8th, that is February, where I will talk about the energetics in muscle contraction. Come prepared for the class. Thank you, one and all.